You're listening to Compliance Conversations, your inside scoop on all things healthcare compliance, auditing, and coding. Now, let's get on with the show.
Welcome, everybody, to another episode of Compliance Conversations. I am CJ Wolf with Healthicity, and today's guest is one that we've had on the show before, but we're excited to have her back. It's Keisha Wilson. Welcome, Keisha. Glad you're back.
Hi, CJ. Thank you so much for having me back again.
Absolutely. We met again at a conference recently, and we said, hey, let's talk about some of the things that you spoke about at that conference. But before we get into that, let's just kind of remind our guests of who you are, what you do, and anything you want to share in that regard.
Awesome. So my name is Keisha Wilson. I am the founder of KW Advanced Consultant. I've been in healthcare now almost 30 years. Funny, I know. Everyone always tries to figure out my age after I say that. But I've held various roles when it comes to healthcare, and I decided to bet on myself as a friend encouraged me. So almost like 4 years now, I started the company. So a lot what I did in compliance when it comes to audits, education, revenue cycle management, I do now as a vendor. I have clients of various areas. So some may have just opened a practice, some has one for a while, and I go and assess. I write policies and procedures. Teach medical coding, so I teach under KW Advanced Consultant, and I also teach for VILT and then New York City College of Technology, my old alma mater. I teach patient care navigation there. And then I also sit on various board of directors, and one in particular is for the International Society of Telemedicine and eHealth. And of course, mental health board and a HIM board and a nursing board. I know, I don't know when I
Wow.
sleep, but that is
Yeah,
a
that's
bit
busy.
about me. Yes, and so main focus a lot on telehealth, risk adjustment, and E&Ms. So we are here to talk about one of my favorite topics.
Yeah, we're going to talk about telehealth, but let me just say, Keisha is a wonderful person, an outstanding professional in this field. So we'll include in the show notes links to her company and to her in case you need her services. We highly recommend you reach out to her.
Thank you.
Keisha, before we jump in, I just want to level set with the audience here. We are recording this podcast on October 30th of 2025. And so the topic we're going to talk about is pertinent today. It'll still be pertinent a week from now, which is when we think this will go live, probably early November. But if anything changes in the next few days, just recognize that the things we're talking about are true and pertinent as of October 30th, and tomorrow may bring some new things. We actually hope it brings some changes to what we're saying today, because we're going to talk a little bit about telehealth and the federal government shutdown. And so let's jump into that, Keisha, a little bit. And because in your presentation at the conference, this was a big part of it, right? Because we're like all have our hands up in the air, like what's going on with telehealth, and so tell us a little bit about this recent federal government shutdown, and how is that affecting telehealth access and reimbursement under CMS for like Medicare beneficiaries, for example?
Okay, and I'm just smiling because I'm like, who would have thought when I think I proposed to speak about this topic at the conference, that we would have had a shutdown,
I know,
right
right?
before. So we knew, since last year when they had the extension, things were supposed to end December 31st of last year, 2024. And then we had some extensions through the American Relief Act until March 31st, 2025. I always have to close my eyes to think about dates. And then we had some more extensions when March 31st. They actually told us 2 weeks before that things would be extended until at least September 30th.
Yep.
So I think many of us thought that, okay, they would extend it again. But then lo and behold, we had a shutdown October 1st. So I knew things were going to be like kind of up in the air. So I reached out, to the board, and I was like, hey, I know my topic is due, but can I have an extension? Because we have some changes that's supposed to happen September 30th. And I want to make sure
Yes.
it's as current as possible because I think I was presenting October 6th. So no pressure at all.
Right.
And then we had the shutdown. I remember I didn't sleep at all that night. I was just watching and waiting and trying to update the slides. And even to the minute of presenting, like down to the hour before, I know I sat in your session the hour before and I kept checking, like, okay, no changes, because I wanted to make sure I brought real time information to those that was attending. But nothing changed. So right now we have a shutdown that has affected millions of Medicare patients all around the United States. And I think I gave that example during the conference. 2 hours before my session, I had a phone call with my mom, and she was stating that a doctor's office called to give her to make a follow-up appointment for her, and it was telehealth. And then they called back 10 minutes later and they said, unfortunately, due to the government shutdown, um, Medicare patients, they have to bring them back in person to be seen. And so this was something that was like real time that was happening. And a lot of organizations didn't know what to do. So that's to show you the landscape that we're in, how the Medicare patients are being affected. You know, I spoke about my mom before, how she's post-stage 4 cancer and different
Right.
things. So when it comes to her white blood count and certain things, you just want to keep them safe, and telehealth has helped with that.
Yeah.
But the shutdown now, they have to go back in person. MLN, they had put out an alert saying that the max should hold certain
Claim.
claims for 10 days, but now October
Yeah.
21st, they sent out another alert saying that they can process claims, but some will be paid, some may not be paid, they're not sure. So you just have to submit and see. And so right now
Yes.
we're in a landscape of we're going back to a lot of how telehealth was before the public health emergency. When it was really restricted, you had to be in a geographic particular rural health area for it to be paid, or
Right.
in a Medicare designated area that is approved for telehealth services. You know, before there was limited amounts of telehealth services that can be done via telehealth as well. Now we know they expanded that list. So we're in a space when it comes to Medicare, like we're not sure with the patients. They're signing ABNs, and I know we're going to talk
Right.
about that in a bit about what they can do. So the advanced beneficiary notice, that's something that is a possibility. Some organizations have halted seeing Medicare patients. Some are actually kind of eating the cost and still
Right.
seeing patients for continuity of care. So when it comes to Medicare, we're still at a very up and down, or I like to say salsa dance. But when it comes to Medicaid and it comes to the private payers, they already had a lot of permanent laws and guidance and policies in place when it comes to telehealth. So it's more the Medicare patients, but it's a significant amount of patients. So right
Exactly.
now, unless you're like mental health, your
Right.
services may not be paid because mental health services, I think it was in the 2022 physician fee schedule, they changed the definition of mental health visits to make
Right.
it permanent, even when it came to some of the geographic areas. And even then, there's some exceptions. Like the mental health thing is so huge where you have to read, and there's some exceptions that I'm sure we're going to talk about some more. So we're in the
Yes.
landscape of the shutdown, restrictions, things not getting paid, Medicare patients having to go back into office. And it's not the easiest when you think about the Medicare populations, because it's normally over
Right.
65, the elderly,
Right.
disabled, if they're under 65. So, you know, really a population that really needs telehealth along with others as well.
Exactly. Yeah. Well, and for a lot of us, let's just go back before the
Mhm.
pandemic even. You already alluded to this, that telehealth was pretty strict and pretty limited. And we just got to remember that because there was a public health emergency and that status could be declared, that's what gave us flexibilities. The law was not changed.
Yeah.
And so for years, we were living under flexibilities because of the public health emergency. Congress never, with some of the exceptions you've mentioned, there weren't like major permanent legislative changes, and Medicare just can't cover whatever they want. They have to get their direction from legislation. And so but we all got used to telehealth during those 3 or 4 years and we loved it, right? So we're all like, hey, telehealth is great. It's all for all the reasons you just described. It's better for patients, it's easier. And then all of those, extensions that you mentioned, the last one was to expire, like you said, at the end of September. Even if the government shutdown had not happened, we would have still been dealing with Congress needs to do something for us to continue, right? And so we just all need to remember that all of these flexibilities existed because of a public health emergency. And now we're dealing with, everyone liked it, everyone saw how effective it was, but the law doesn't really allow for it. And if we don't have a formal declaration of a public health emergency, we don't have those flexibilities. And so so for everything you just said, and before we get into some of the other specifics, let's just pretend that there hadn't been a government shutdown. Correct me if I'm wrong, but I believe you said there was legislation moving along in Congress that had bipartisan support, that if the shutdown had not happened, that probably would have passed, and it probably would have done what? Is that, what would it have done? Did I first of all understand correctly that there was legislation, and if it had been passed, what would have happened?
Yes, so I'm going to give a few answers because you said a lot of good points there too. So over the weekend, I think it was October 25th, Sanal Patel and I did this telehealth playbook workshop. It was 6 hours, and we had the president of the International Society of Telehealth and E-Medicine. She came and she presented, and it was from a physician perspective because she talks a lot when it comes to Congress and all over the world and internationally about telehealth and policies. And so it was amazing to hear the difficulties or the frustrations from a physician perspective when they want to take care of patients and there's just the restrictions. But she's been an internal medicine provider for 30 years, so she's seen the landscape of telehealth. And during this session, I think I did this once in HealthCon, I talked about the timeline of telehealth. And so a lot of us now got familiar with telehealth, as you mentioned, because of the public health emergency. This is what we had to do to see our patients and just for continuity of care. But telehealth has been around since the early 1900s. And if you go back, even the 1800s when we talk about the phone, but early 1900s where they used like television and radio, then NASA used it. So everyone always asks, is telehealth going away? I always say it's not going away because it's actually been around longer than most of us has been alive, right? But we have to get Congress and other payers on board to make certain legislations permanent when it comes to telehealth. And we have to learn how to do it compliantly. Because during the public health emergency, we just we were up trying to see our patients. It wasn't always on the compliant platform. And so that's after the public health emergency, as of August 9, 2023, we must all be on a HIPAA compliant platform, but not everyone is. Right. And so before telehealth, as you mentioned, or before the public health emergency, it was really restricted. You had to be in a rural health area. If you were in FQHC, it was like outside of a non-metropolitan statistical area. It was paid on a limited basis. And there was a limited amount of providers that could bill for Medicare services. So Medicare also has a permanent list of telehealth providers, like the MDs, DOs, nurse practitioners, PAs, nurse midwives, psychologists, licensed marriage social workers, they're on there, and I think dietitians are on there now too. But the PTs, OTs, speech language pathologists, as of September 30th, right now, they cannot provide services anymore. So we were in a real restricted area. Some places, if they did bill for telehealth before the public health emergency, they had grants. So I remember I worked in one particular hospital in New York City, they had a grant, and that's how they got paid for telehealth services. So now there are, and that's why I say it's not going away, the American Telemedicine Association, the ATA, they continue to foster and lobby. They had a letter written on President Trump's desk, even the day he was inaugurated, talking about making a lot of the flexibilities permanent, right? Because when you think about mental health, you have HRSA, the Social Work Compact, who is licensing social workers in all different states because of the significant increase in mental and behavioral health, right? So you have a lot of people who have virtual practices. So it's like, okay, well,
Right.
what are they supposed to do now when it comes
Right.
to the landscape of, well, you need to have a location or we need to have an in-person visit. So we have a few bills that was on Congress desk waiting to get approved. And then the shutdown happened. So we had one was the Connect Health Act, which is looking to make some of the flexibilities when it comes to geographic restrictions. They're looking to make it permanent. Um, and when you think about it, it makes sense, right? So someone
Right.
would not have to be outside of a metropolitan statistical area to get telehealth services. Then it was
Right.
going to also expand the eligible providers that can provide telehealth services. Another one that was on their desk, I think, is the Telehealth Modernization Act. That one was
Okay.
definitely on there, and they're looking to continue some of the flexibilities that happened post public health emergency. They are looking to extend some of these flexibilities at least until 2027. So
Okay.
it just happened that the shutdown happened while we were in this dance. I think
Yes.
they know that as of September 30th, that they were supposed to have the shutdown. They needed to have some things in place, and then we just got stuck in between.
Right.
And then we still have the Consolidation Appropriation Act of 2021, now 2023, which we're making a lot of things permanent or trying to
Right.
make a lot of things permanent that's still there when it comes to the flexibilities. So right now we have at least those three, and then there's the Telehealth um, Coverage Act, which was
Yeah.
proposed, and that one was supposed to like make audio only services permanent when it comes to telehealth. And as you mentioned before as well, there's some things that Medicare can make permanent on their own that's, within their within what they're allowed to do, but there's other things
Right.
that they have to get Congress approval. And unfortunately, the geographic restrictions and
Right.
certain other things are just in the hands of Congress. And now we're kind of waiting to see what that looks like.
Yeah. Let's talk about some of those things in a moment. We're going to take a
Mhm.
quick break and then let's come back and talk about that specifically.
Compliance is complex, which is why you should visit Healthicity's Resource Center. It features updates on the OIG's new General Compliance Program guidance, CEU webinars, and more. Visit healthicity.com/resources today.
Welcome back from the break, everybody. We were talking about some of the legislative actions that have occurred and that were about to occur, and then the shutdown happened. So basically, eventually the shutdown will end. I have no crystal ball. I don't know when that will be, but eventually it will. And Congress can hopefully then act on some of those laws, and they have done this in the past. I don't know that they'll do it. Sometimes they make things retroactive.
Yeah.
And so to your earlier point, that's why some MACs were saying hold the bills, right? You talked about ABNs, but let's briefly just say in a nutshell, as of today, if you want to guarantee reimbursement, you have to revert back to the pre-COVID rules with a general kind of high level exception about behavioral health, where those you can still, I believe, the patient can still be seen in their home, whereas all the others kind of require this other site. Is that a good high level general statement? And I know there's probably some exceptions, but is that generally true?
Yep, it's generally true. And there's so many, exceptions. But unfortunately, right now, and CMS and we will link it for you all to see in case you didn't. CMS came out with an FAQ. It's about 5 pages long, and they
Okay.
answer a lot of these questions. And
Okay.
so they mentioned one, if it's non-behavioral health right now, unfortunately, you have to go back into an office. To be seen, and it has to be an approved location. So a lot
Right.
of people didn't even know that Medicare had a telehealth payment eligibility analyzer.
Right.
I showed it in my
That's right.
slides at the conference. And so if you go right now, it has a blurb, as with everything that you go, all government sites, when you go right now, there's a blurb that said right now there's a shutdown, so it may not be updated. But organizations should use that analyzer going forward after that to make sure that you're within a certain area that you will get paid, right? Because right now we're going back to that pre-public health area. If you're not,
Right.
if you're not within a non-metropolitan statistical area, then the
Right.
FQHCs and RACs right now, they're kind of covered because of that mental health law that they passed
Right.
before in 2022. And the FAQ also did mention an update when it comes to in-person visits. So they mentioned
Okay.
that if you did not, like, as of, September 30th and on, you definitely would need an in-person visit. If you did not have one prior, um, basically they're honoring that, but as of now, going forward, you need to. If that provider is not available, then someone else within the same subspecialty
Okay.
can provide that in-person visit that has to be recorded in CMS database for those behavioral mental health services. So you think about those psychotherapy codes, those
Right.
90791s, 90792s, and the group therapy, individual therapy, that would need to be recorded. But again, you can see why the ATA is fighting
Yeah.
to make a lot of things permanent, because there's a lot of providers that are affected. And then you think about
Exactly.
the elderly populations who, when I teach the patient care navigation course, even though we live in such a big city, for example, New York, there's still a lot of patients that have social determinants of health where they can't.
Right.
Transportation is a huge issue.
That's right.
So how do they get, even in a busy city, right? Because there's crime,
Right.
people don't want to go on these things. So you
That's
think
right.
about the patients that is affected when it comes to those areas.
Yeah.
And then
So
audio only as well, like you said.
yeah, yeah, exactly. So now when you were on the show before, and this was maybe like spring of 2024, we were trying to figure out roughly when it was. We'll find the episode and link it to this one. We discussed at length ABNs. So we don't necessarily need to go into all the details about ABNs, but tell us about how some have been encouraged or potentially that idea has been thrown out there, and about, because these services aren't necessarily covered right now, having a patient sign an ABN, and have you actually seen people doing that, or are most of them not?
I'm now seeing them start to do it. I think they had forgot about ABNs. Believe it or not, in 2025, there's still a lot of organizations that don't even know what an ABN is. And that always baffles me, but
No.
we're still there, right? So we have to train our front desk and administrators that ABNs, this is a time, advanced beneficiary notice. So you give it to your patient in advance. And I had
Right.
someone that attended the workshop over the weekend that asked a good question. She was like, in my organization, we saw a whole bunch of Medicare patients and we didn't. Can we go back and now have them sign those ABNs? And I said, no. CMS
Oh,
talks about that. If you don't give it to them way in advance, you can now not have them sign it because you forgot to give it to them. So they
that's
have
right.
to have a choice to know that they may now be responsible for this bill, and that's what the ABN is. There's options.
Sure.
There's 3 options on there you can check. There's modifiers that would be applicable. You have to write the service that it is, how much it costs, and the patients have to know that it may not be covered and they're going to be responsible for their bill. Can they do that? If you did not provide that to your patient before, then now your organization will have to, waive those visits. You can now not bill those patients for those visits, and it was your fault. So
Right.
organizations should go back, listen to those ABNs, make sure your organization has it. The most current one is set to expire January of 2026.
Okay.
And so if you're using an old one, that's still considered null and void, like you didn't even do it. And
That's
you
right.
need to make sure it's signed and filled out in its entirety. So I think people forgot about
Yeah.
ABNs, and that would be an option, even though MLN said it. So we're
Right.
gonna link that for everyone as well, so you can read it.
Yeah.
And it
So
comes in
so
English
far,
and Spanish, and
exactly.
and small print for those that wear contacts and glasses.
Exactly. So the majority of what we've been talking about so far has been Medicare. You did mention Medicaid a little bit, but can you just briefly tell us what are commercial payers doing? Are some commercial payers still allowing telehealth? I think some commercial payers are finding telehealth to be a benefit, right? And may have continued these benefits. Tell us a little bit about what you know there.
Oh, yeah. So I would say a lot of payers, private payers and state Medicaids have permanent laws and policies when it comes to telehealth. And even like New York State Medicaid, I use that as an example all the time. Sorry, because that's a state.
That's good.
But they had about the payment parity and that they're continuing to pay under payment parity. So they're paying those telehealth visits as they would in-person visits until April of 2026. They also have about place of service because they want to see something other than 02 and 10. They want to see 11 for payment parity. So I
Right.
always tell everyone, make sure you check your specific payers because each one wants something different. One shoe doesn't fit each,
That's right.
but right, it holds true to the payers. Commercial payers have actually policies on their websites regarding telehealth. They are paying it. They're paying payment parity as well, but there's specific modifiers, there's specific codes. So a lot of payers, private payers, did not adopt the new AMA codes, the 98 series
Right.
codes. A lot of them were
That's right.
following what CMS did, and they were using the outpatient E&M visits with the appropriate place and service and modifier. And a lot of state Medicaids are doing that too. I think we had just a few sightings of a lot of the blues, like Florida Blue, Alabama Blue, that were paying those 98 series codes. So
Okay.
that's to show you that you need to check your payer policies. But also, what payers are also doing is they have their own platforms and their own physicians
Right.
to provide services. So they may not approve your provider to provide services. They may actually want that patient to be seen by one of their providers on their platform. So that's why I
Exactly.
tell everyone you have to check eligibility. You have to check your payers, your patient's insurance to see if it's approved, if your provider is approved. You can't assume because a
That's
patient
right.
has Aetna that is going to be covered, and you have 10 patients that have Aetna. Each policy is
That's
different.
right. That's right. And Aetna might sell a Medicare Advantage plan. And
Yes,
so it might say Aetna, but it's really Medicare Advantage. And so,
correct.
you probably run into this a lot with your clients. I know I get it with my clients. They say, can we bill telehealth? Sounds like
Yes,
a simple question. And the answer is the short answer is it depends. And the long answer is part of what you started, which is what state are you in? What
yes,
payer are you trying to bill? And
yes,
so because people hear on the news telehealth's not being covered and they think that's the world, and in Medicare and some parts of it are, but a lot of it isn't, but that's Medicare. And to your point, your answer you just gave, check with your payers, check with your states. It's
yes,
very, very unique. And I've even seen some payer policies say use this place of service as
yes.
to what you were kind of saying that's different than what Medicare says. And so you just really it's frustrating, but you have to go through that exercise.
Yes. And I feel like some clients like they may get annoyed when you say, "Well, each payer is different." And I hear the students when you teach the billing, they say that too, but
Right.
I'm like, "No, it's really true." And then I have a sign on my desk. I always like to show it. It says, "Oh, this calls for a spreadsheet." Um, and it's be literally because you also have to create a spreadsheet for everything, like for the payers,
Right.
what modifier, place of service. Each one is different, and you're seeing that when it comes to telehealth. So, getting I encourage organizations to teach your front desk to check eligibility, check if it is a part of that patient's plan, because it starts in the front. And I realize that they're not doing that. Sometimes they think, oh, the front desk doesn't need information about telehealth, but they actually do. They need to understand the whole scope so that they can, check and make sure it's covered before the patient comes in.
Yeah. Well, Keisha, we are kind of coming towards the end. I know we haven't gotten to everything that we had planned to talk about, but maybe we have you, and I know not maybe,
Part
we
two.
want to have you come back and maybe talk about once the government reopens and maybe some of
Yes.
these laws pass and get signed, have you come back and kind of tell us the fine print there. But, as we're coming to a close, are there any last minute things that you think are really important that I didn't ask about? Or, kind of parting comments that you'd like to share with everybody before we close?
Yes, so I think one, I remember last year in one of the presentations I gave, I talked about the different states, and a lot of them had passed recent bills making audio only and certain things permanent. So again, that's to show you how when we're talking about telehealth, there's a lot of stuff on the federal level, but we have state levels as well. So you have to go back to what you said, CJ. What state do you live in? And then look at
Right.
those state laws because they already have permanent stuff when it comes to telehealth and audio only services. So you have to research. That has to
Right.
become your middle name. I always say that's my middle name. That has to become your middle name when it comes to this. There's a lot when it comes to telehealth. I definitely think a part two because there's so much when it comes to mental health services and non-mental health services. But for now, you want to check your resources, look at Medicare. If you have a significant amount of Medicare patients, look at the Medicare FAQs, go back to your Medicare manuals. A
Right.
lot of stuff already set in stone when it comes to FQHCs and RHCs. There's a manual for everything.
That's
Um,
right.
and then look at your state laws, look at your Medicaid states, and do not just take, okay, because Medicare did this, we're going to stop seeing all patients. That's not
Right.
it. That's where policies and procedures come in. You can still see Medicaid and commercial payers, right? And
Right.
then you just have to look at your Medicare clientele right now and decide, are you going to sign ABNs or are you going to halt it and bring them back in person for a time being?
Yeah.
So research, stay abreast, read the links that we put, and stay in tune for part two of when the government opens and what's next. Because there's a lot
That's right.
actually for 2026 that we didn't get to talk about too.
Okay. Well, good. Well, let's have you come back when some of the dust settles a little bit. And I know you're working on other things unrelated to telehealth that we'll probably want to have you back and talk about as well to kind of tease some of our listeners about some of the other things you're doing. So, Keisha, thank you so much for taking the
Thank you.
time and your willingness to share your expertise.
Thank you for having me back. I enjoyed it. Have an
Good.
amazing day, everyone.
Yeah, it's a pleasure talking to you. And to all of our listeners, we always like to close with this, that, if you know of a speaker or a guest that we should have on, please let us know. If there's a specific topic that you would like to hear discussed, please let us know. We want to make this useful to you. And until our next episode, take care, everyone.